get started, thank you very much for coming to this panel session. I'm delighted to be hosting this panel session today. My name's John Veazey. I work at a not-for-profit organisation called the Satellite Applications Catapult. I'll just ask our panellists to introduce themselves, who they are, where they're from, and then we'll start a bit of a debate. We'll have some questions at the end from our audience, and then we'll go from there. So David, if you want to start.
David Davis, been a paramedic since 2004, worked in the NHS ambulance services since 2001, but done a few national jobs around clinical informatics. Recently just did the Digital Academy programme, NHS Digital Academy programme. In fact, I put my master's submission in last Wednesday, so hooray, but what's that taught me, I don't know. And I'm a Thames Valley Air Ambulance trustee as well.
Hi there, my name's Nigel Harley. I joined the ambulance service similar time to David, 2004. I've had various roles as an emergency care practitioner, worked in universities. Currently I work with the critical care team in Hampshire and Isle of Wight Air Ambulance as a critical care paramedic.
Hi, my name's Sally Eastman. I work for Arden Gem Commission Support Unit, so my background is in transformation and change management, and I'm currently Associate Director for our Digital Transformation and Service Redesign Service. So we work across health and care communities, helping people to really think differently about their care pathways and collaborate with a lot of digital partners to help to sort of change the way people do things.
Thank you. Hello all. I'm Simon Hill. I'm the Technical Director at Accelerate Technology, and we supply communications technology to various sectors, but we've been supplying resilient and redundant communications pieces to ambulance services since about 2006.
David, if it's all right to start with you, just from a point of view of where do you see digital transformation coming into your role, and how has it changed since you started?
I should have sat at the other end.
Yes.
Okay, so before I joined the ambulance service in the NHS, I used to work in an IT startup, funny enough, for a famous comedian's dad. And I was quite shocked in 2000 to come into the NHS and discover email wasn't working, there were no electronic patient records, there was no integration across any of the system. And 21 years later, it's barely any better, apart from the fact that email's drowning all of us. So if the question's what do I see as digital transformation, it needs to be easier, because I think lots and lots of people find the journey to digital just adds greater burden, email traffic. It takes longer to clerk a patient when you're using an electronic patient record. Actually, there's more stuff coming at you in all sorts of directions. If you're a paramedic like me, once upon a time there used to be a folder on station which you'd sign the front of to say you'd read it. Now you have to open 600 emails after 2 weeks off. So for me, the digital transformation journey starts making life easier. It allows us to collect information about patients more quickly. It brings information across all the sources together and allows a patient to be not just an event that happens in front of you as part of their overall healthcare journey. And my fantasy is as a paramedic where my burden is lighter and my focus therefore can be more on patient care.
Nigel, do you want to give a bit of a view from your perspective on digital transformation?
Okay, so from my perspective, seeing the way technology has been introduced into the ambulance service, I think that a lot of the education in terms of when we're introducing new technologies and how we educate our staff to actually use these pieces of technology and embrace it, you have a lot of different skill sets within the ambulance service. Some people are very tech savvy and some people are not. And I think the culture of embracing that really needs to be underpinned from an early stage to support clinicians in how to use the technology effectively, whether it's a new iPad or a new defib device, anything like that. There should be sort of effective educational measures and a framework around how do we use this technology, how is it integrated? Because if people don't know how to use it, it won't be used effectively. And what we always want to do is expedite our scene times. We don't want to be on scene any longer than we need to be. So if we educate our staff to use the technology properly and troubleshoot all those issues early on, then they can embrace that technology. Their scene times will be quicker. And one of the things I found in my practice was that trying to do pathways and referrals would take a long time. If you have a service directory or a single point of access, you can utilize that technology, refer on to GPs, refer on to other services. It's like a one-stop shop, but you need the right technology with the right emails and the clinical pathways there. And I think that's it's a very much a developmental issue in terms of where you work, where you live. A bit of a postcode lottery. So some patients in one region will get a certain service commission commissioned, and you could go to another area and that service is not commissioned, so you may have to take that patient to hospital. So the technology may be there, but the pathway needs to be there to support that technology and to embrace that. Again, education and a proper governance framework. So I think that's, from my perspective, quite a key issue.
I think it's quite interesting because I've come from a slightly different perspective, and I don't disagree with my colleagues' aspirations as much as anything else, but I think that we need to make digital work for us, not be a slave to it, and I think that's about changing the balance and actually getting practitioners to help to shape and redefine and understand what can technology do for them as opposed to what technology will make them do. And there is a fine line, because sometimes people do need to start to, see the art of the possible. Underpinning all of that is actually having the the sort of ubiquitous connectivity everywhere. That's a high level of reliance and resilience, because that actually helps to sort of like almost determine the nature of the changes that are undergoing. But I think the other thing is really important is the role that patients play in all this. I mean, we are all digital citizens now, and patients, it can really revisit and reshape the relationship with patients, the level at which that they can start to manage and run and sort of like understand their care, the way that they engage with clinicians and practitioners, paramedics and others. That they can be very much in the sort of driving seat of managing their own care in a way that they perhaps weren't. I think we need to embrace that more. And I think one of the things that, certainly from our perspective and from a commission perspective, there is this bit about not dropping technology onto people, but understanding what technology can do, and then how do we maximise its impact for sort of local circumstances and pathways.
Simon, you obviously from a Accelerate point of view and from partners that you work with like Visionable, this probably isn't news to you, this idea that you want to have technology that works with people rather than you have to work around it. But how do you take that on as a responsibility for you as an organisation? How do you design things differently?
So we're very much focused on making sure that the technology, if you like, blends into the background, and that you don't need to have a degree in Accelerate in order to operate the technology that we've given to you, because at the end of the day, the people using it, if you're a paramedic, your job is there to be a paramedic, not to be a comms expert. So we're really focused on making things as seamless as possible, that hide away in the background, but give that that ubiquitous connectivity that's required. You can't change your operating procedures to use remote services, remote consultants to help make decisions or whatever that might be, if the connectivity is always there. It has to be there all the time, but it has to be touch proof. No, you shouldn't have to touch a button or do anything with the comms piece. It should just be there in the background. And we've spent a lot of time making what I call as simple stupid as possible, and that's not because we think any of our users are simple or stupid, but it should just be that. It should be like an iPhone. Pick it up. You don't need to be taught how to use it. It's intuitive and it's there. We very much take the same approach.
Sally, one of the things I just wanted to check on, because obviously you've heard Simon talk about that approach of having ubiquitous connectivity, and you referenced it yourself, but how do you see that working in terms of aspirations towards that integrated care that we know that paramedics need to interface with different parts of the health ecosystem too?
Well, I think it's going to be absolutely crucial to really looking at the future integration of health and care, because we need that more than anything. And when I say care as well, I think we need that in its widest sense, so that we don't have two-tier systems, because we've got quite a lot of hospitals that are digitally mature, others which are not so. But when you move into the social care sector and the independent care sector, there are some almost third world backwaters there. So, and I think that sort of connectivity and platforms and accessibility across those need to be seen in that context. I mean, a little bit ironic about the debate going on in Parliament today about how we fund things, but actually one of the things that make the effectiveness across all systems is high levels of communication, ability to see patient records in the right places, being able to respond differently, and in contemporary society, that level of connectivity is absolutely crucial to that.
And for you guys, for Nigel, for you, David, how do you see that in terms of your role, in terms of interfacing with so many different parts of the ecosystem? Obviously, at the ambulance, you have your own challenges and faces, but you obviously have lots of interfaces with, as Sally describes, lots of different parts of that whole care pathway. Where do you see the challenges most prevalent?
Having previously worked in sort of primary care and worked within the sort of collaborative teams, the multidisciplinary teams with social care teams, nursing teams, community matrons and that kind of stuff, working with these guys is really key, and being able to access them and knowing the pathways that are available is a key part to how we work. So there's many clinicians not just working in emergency services but in primary and urgent care, and knowing how to access those pathways with the technology is absolutely vital. And again, that goes back to commissioning and having the pathways put in place. So being able to refer directly to a mental health team and linking with them and get the right services to the right patient at the right time is invaluable, saves a lot of money, avoids unnecessary hospital admission, and that's where the technology, again, going back to the Accelerate and making sure that you've got high quality streaming. So if you can restream to a consultant psychiatrist with high quality and they can see the patient, you can have a three-way conversation with that patient and that consultant, then that patient is going to get far better care. But it's making sure that service is available, are the consultants available? If they're not, then what else is available to those clinicians?
I just wondered if I could just pick up on that point as well. You mentioned the sort of commissioning of the pathways. I think one of the things that we are probably not doing as well as we could be or thinking about is commissioning digital pathways. And that often digital is an add-on, or how do we do this digitally, not actually what would be a different way of doing that. And I think that's what we collectively need to engage and aspire to.
Yeah, I think you're going back to that, you're absolutely right in terms of you can, in regards to sectioning a mental health patient in crisis, doing that virtually, there's a lot of contentiousness around that. You can discharge them virtually, but you can't admit them virtually or give them a section 136. So that's a very different, that's the same sort of problem that we're going to come across. So what is legally allowed?
So in trying to answer your question, I think the number one thing to remember is the complexity. So again, just wearing the kind of ambulance service paramedic hat, if you think about the different pathways and interfaces, both in the referral space but also in the clinical support supervision stuff, there's just so many things. One of the areas where it's working better than it has is between 111 and the emergency operations centres via the DOS, where GP Connect allows you to book appointments directly with GP practices and the emergency departments. But I was working on the phones last week and the slots were full. I then had to go to the directory of services. The GP practice hadn't put their non-patient facing number there, so I had to spend an hour in the queue waiting to make a referral, and I could have spoken to 4 or 5 other patients. So some of our integration challenges require commissioning. They also require the whole system to understand that we're working together. So, and that's just one area. And then you have to remember that the average ambulance service has 20 plus places to refer to. Some of the things that we need to enable it, and I've been working with colleagues on, is an ambulance to care location or ED standard, so that there's a minimum data set that can be shared. And we've got things like ambulance data set coming around the corner. But all of that requires a shared understanding of what you're trying to achieve. And I agree with what Nigel said earlier, just looping back. Training is really essential. Yes, develop intuitive stuff that's always connected and works every time, but equally we know the number one barrier to benefits realization in electronic medical records is training, and it takes 7 to 9 years to realize benefits. I just share something that I learned last year. In the US, some hospitals are advertising consultant jobs where they have paper records because people hate electronic records so much. That is our challenge. Our digitally enabled environment needs to be enabled, not disabled.
On that point, actually, I think it's absolutely true. But one of the things that we need to be forward thinking is that we would probably consider all ourselves here to be digital citizens, but our generations below us are going to be very digital citizens, aren't they?
Just like going back to thinking about innovation and technology in practice. Now, I'm pretty sure that all of us, if we're clinicians here, we've been in an incident where you're not quite sure what to do. if you can embrace the technology, it happens now, and you have a patient that's very, very unwell, if you've got the technology there to support you and to link in to a consultant or a senior clinician to advise you on what to do with your patients, isn't that just golden? Because if I'm in a job now working in critical care, it's pretty sharp. It's low frequency, but they are really intense incidents. And if I'm there and I'm not quite sure what to do or what region to go to or what hospital to go to because I'm struggling to manage an airway, if I can have a consultant seeing what I see, hearing what I hear, and to help me come up with a clinical management plan that will benefit the patient, you are getting really high quality care from the hospital at the patient's side. Now that is an absolute dream, and that's where I want to see things going, and I will feel reassured and I feel supported. And if that sort of technology is recordable, it also is evidence, and you can peer review it. And that again goes back to governance, but it also goes back to having an open culture. That culture where you feel confident that you can actually be critically appraised and you can have critical feedback, which is all constructive, and you can actually learn from your positive experience, and you can learn from where you haven't done things quite as well as you could have. And you can also explain the context. Maybe you've had 4 serious jobs one after the other and you haven't eaten. You've got that technology there to give you that buffer. That bandwidth is not going to be so maxed out. You've got the technology to help you, and you're supported in your decision making. And that's where I see the technology really enhancing care. But care is an unmet patient need, but it also for a clinician need.
Yeah, David?
I mean, the danger of Nigel and I agreeing too much here, but when I first started as a pre-hospital clinician, and I was first the senior person after about 4 or 5 years, and I faced that situation where I wasn't sure, I couldn't get support. There wasn't even a phone signal. It doesn't need to be like that, but it might be in the audience here that there's some vendors or some suppliers, and I think it's everyone's responsibility, and particularly people designing, whether it's medical equipment or technological solutions, to anticipate to need to work together. Actually, it shouldn't be that when Nigel's in his fantasy talking to an expert who's providing him some support on video, that he has to read out the readings from the physiological monitoring or interpret the ECG. That should all be planned, integrated into the view. That it needs to be as easy as possible.
Yeah, so Simon, do you want to touch on how yourselves and Visionable are working on that sort of approach?
Yeah, so I was just going to say, actually, it must have been about 3 or 4 years ago at this exhibition, and a consultant from UCL came on the stand and was talking about maintaining connectivity in ambulance. This was before we were really considering it. We were really focused on command and control vehicles, and a bit of time passed and nothing happened. But he came back, and we actually successfully. It was all about maintaining two-way video with an ambulance back to a hospital when they're transporting a particular patient from. The use case here was London to Brighton, and we did several trials with them and maintain that two-way video call on that journey, which if you've ever made that journey, you'll know you can't hold a phone call let alone a video call. And that proved so successful that they've started to roll that out in the private ambulances they're using for this particular use case. So it's a good example of it working in real life. And fast forward on now, working with partners like Visionable, who have got the application and make it so easy to be able to not only share people's faces and see each other and hear each other, but linking in some of the medical equipment that's already on an ambulance that can be connected but isn't, to consultants and specialists and anyone else who needs to be in that mix. But again, it doesn't work unless there's that connectivity. So join it all together, make the interface, the user interface, which is the Visionable piece, simple, stupid, that you can sign in like you do to Teams, and you can work it like you could with any other application. And our bit, the communications bit, just blends into the background and is just there, and you don't have to worry about which connection you're connected to. It's bonded together. It's flicking in and out of networks without you needing to worry about it. The important bit is that in this case the paramedic can communicate with that consultant and not worry if they're going to lose signal. In our day-to-day lives, we all know we we go places and we can't do what we want to do, whether it's Facebook or FaceTime or Google. You know, when you want it, when you want to find that place on Google, you can't because there's no connectivity, or even when there is, and it gets really contended because so many people at the same event. So having a blend of communications and you know, knowing what we can do to make that ambulance in this case as connected as possible, you know, is a big thing for us. We're in a process of rolling out every ambulance at Hamad Medical in Qatar in the run up to World Cup. Their view is, with reducing conveyancing to hospital, you know, being able to help a paramedic make decisions on the roadside or at somebody's house without taking them to a hospital. If they can reduce that, they can save more money than it will ever cost them to install this kind of technology.
So yeah, I'll just add on to that. If you've got all the right diagnostic equipment and the paramedics will then perform those diagnostics, and you can add that to a file. If they're not going to be conveyed to hospital using digital technology, and you can send that file to their primary carer. And so, I mean, my dream would be if you could have lung sounds recorded on a digital steth, or heart sounds, or anything like that. And if someone's trained effectively in using ultrasound, they could do a scan or the ECG. All that file in one big file could be then sent to the GP, and then they are safely left at point of care testing. So you're ruling certain differential diagnoses out, and then you can send that file to the GP. The GP can then download that, and they see that there's been a thorough review of systems, and they're safely left at home, or they're referred on later on to cardiology or to neuro or whatever else, safely and effectively. So there's the safety element of it too, and it's a digital file that's always going to be there. I think that would be a beautiful thing.
I think I know it's completely possible. You know, whether all the equipment's on an ambulance yet, you know, I'm not sure of in every trust or around the world. But you know, on paper, the ability to do it, you know, we're able to do it. But you know, going full circle, it's as much about the technology as it is about embracing on the ground the technology and the confidence in every facet of that for it to actually be used. But yeah, there's some fantastic trials going on with different types of health-related telemedicine or remote medicine, which are proving very, very successful. And the last few years, as unfortunate they've been with COVID, I think the people have got more relaxed about that remote working, and I think that's starting to feed out into other things, you know, like we're talking about today.
So I think that's probably a good point to pause and thank you each for your contributions. We've managed to cover everything from the needs for training all the way down to the specifics of, you know, how would you respond in a major incident. There's plenty more that we could be talking about. If people wanted to carry on the conversation informally, we've got the stand behind us with people being available for the rest of today, as well as some of you being here tomorrow. So please come on and have those discussions with us. Come and talk through what some of those examples could be. I'm sure these guys will carry on talking about what some of those dreams or potentially realities we could create together. And finally, from myself, I just wanted to thank you all as panelists, and look forward to carrying on the conversation.